Welcome, everyone. I'm so glad you could join us today. My name is Aline Sigler, and I'm with Provider Outreach and Education. Also on the line with me are a couple colleagues of mine, my friends and coworkers. I have Karen Curtis helping me out. I also have Shakura Harris on the line. I want to thank them for being behind the scenes with me today. This session is part of a recurring series where every quarter we've been looking at frequent error codes and their resolution for our Part A providers. So those providers who bill on the UB04, the CMS 1450, the 837I electronic equivalent. So facilities, institutional providers. We do have a similar series for Part B providers who bill on the 1500 claim form, where we're analyzing claims from different specialties. So if you're interested in that, you can check it out on our YouTube channel as well. Now, the purpose of this webinar, why we're doing this series, is to review some of the most common reason codes that we see on outpatient hospital claims. Realizing that we have a variety of provider types on the line, a variety of experience levels. A little bit of background here. Reason codes are edits or errors that occur within the fiscal intermediary standard system, FIS, direct data entry, which is your way to get into those claims. So those reason codes, when we're reviewing those, is so that we can avoid the errors that result in unpaid claims. We get paid to be a claims processing contractor. We have to make sure that we're doing it properly, though. So it behooves everyone to get those claims in as correctly as possible from the get-go so that we can process them efficiently and that you can be paid timely. So we're going to start with where we got the information, what that data shows. We're going to look at the top categories of edits, and then we're going to analyze ways to correct them, of course, but hopefully we want to prevent them from happening also. We'll finish up, like we usually do, with some resources where you can go to get more information on the different topics that we cover. One final note on this slide here, this small footer has a little note about disclaimers. Now, in the past, we've moved them to the end of the presentation. That's where you can find them, those different disclaimers that we have and that we're required to share with you. So starting with data specifics. Here at WPS, we have a lot of internal business units, departments that review claims data on a constant basis for a lot of different reasons. Each department has their own function and their own scope of work that they're responsible for, but it all boils down to us being your Medicare administrative contractor, processing your claims, reporting what we're seeing on claims back to CMS. So there's a lot of different reasons why we use claims data. And we have a database internally that we use that continuously rolls up claim specifics. And so I went into that database and I was able to look at and filter that information to find the pool of claims that we're going to be discussing today. So starting with the time frame, what window of time are we looking at? Claims submitted between February 1st and April 30th of this year. When I went in to create this presentation, that's the window that I was given. That's the information that I had access to. Now it's claims submitted, so the dates of service could be outside of that date range. So I wanted to clarify that. I filtered for rejected, returned, and denied claims. Because hopefully if we can catch and correct edits before they reject, we're going to save ourselves, and I mean you and us, the time and the expense of submitting adjustments, appealing claims, or rebilling things. It's more efficient for everyone. Also within that database, I filtered for just the bill types that you see here because today we're specifically focusing on outpatient hospital claims. So we have a 1-3 whatever, the X indicates any other digit, a 1-4, and an 8-5. So we have outpatient hospital, we have the non-patient labs, and then we have outpatient critical access hospitals. After sorting, I was given 365,903 claims. So that is the claims that we're going to be looking at. What did that show? I filtered those results in the database for the reasons behind them being unpaid. So we had 222,673 that were rejected. So rejected in FIS or DDE means that there's some kind of technical or billing error. There were 108,464 claims that were returned to provider. So that is location TB9997. If you're just starting to learn about Part A claims, you're just starting to learn about FIS and DDE, some of this terminology may seem Greek to you. But what return to provider means, what the status location tells you when you're looking at your claims in the system, means that it was sent back to the provider's online location for correction. So I need to clarify first too, that claims in this location are not finalized. So they're not rejected, they're not denied, but they're not going to go any further without some action from the provider. And then finally, there were 34,766 claims that were denied. The term denied in FIS terms means that there's some question of medical necessity or there's some coverage criteria that is not met. It's more clinical in nature. So I wanted to define those two terms because sometimes we use rejected and denied interchangeably. I might say a claim denied is a duplicate when in reality it rejected. So it might not seem like a big deal, but the actions that you take for each of those is a little bit different. So they are different in technical terms. Now the total dollar amount for these unpaid claims is shown here, almost $282 million unpaid. So I added this slide because it illustrates the breakdown of those same statistics by contract. Jurisdiction 5, if you're not aware, consists of the states of Iowa, Kansas, Missouri, and Nebraska, but it also includes some facilities in other states across the country that might be part of a chain or a healthcare organization. Now, Jurisdiction 8 consists of Indiana and Michigan. And this comparison is here just so that you can visualize where your facility is in the grand scheme of things here. Not trying to compare the contracts as far as one's doing better or worse than the other, because there really is no comparison that way. We don't have the same number of providers, we don't receive the same number of claims, etc. And so this is just so you can kind of see where you are with your jurisdiction. So when looking at the data, it showed a variety of error codes. FIS has hundreds, if not thousands, of reason codes. And so when looking at those reason codes and the description, or what we call the narrative of those errors, can be very similar. So I took the most prevalent ones that showed up in the database and I combined them into the categories that we're going to look at in just a moment. We're going to go over these in more detail. That'll give you a better idea of what they are, what they mean, and what to do about them. I do need to tell you that I bypassed denials or rejections where a claim was billed non-covered on purpose. Some of you know that there are instances where you have to send a non-covered or no pay claim based on CMS regulations. So if there was a situation where maybe you just needed a denial for another insurance company or an encounter claim, a patient that you know has Medicare Advantage, those types of situations that occur on inpatient claims, I just bypassed those because even though they're unpaid, they're not really an error. So I did want to give that disclaimer as well. So we're going to break down these unpaid claims. And even further than by contract, we're going to look at them based on the type of bill. And that's what we're going to do next. On the outpatient claims in the data sample, here are the top 5 categories of errors. Just going to read down the list here, and then we'll explore them a little more in just a few minutes. So with our 1-3X bills, we had claims where Medicare is not the primary payer. We had a lot of claims that were not submitted timely. Value code 44 and the obligated to accept as payment in full amounts are not equal. I know that's a mouthful, but again, we'll explain it. Claims that overlap a Part A skilled nursing facility stay and services that are not separately payable. Moving on to our 1-4X laboratory claims. We did see some of the same errors in the top 5, just in a different order. So you can see here, their top 5 was rounded out with screening cardiovascular blood tests being billed too frequently and lab tests that were not medically necessary. For our outpatient critical access facility claims, they bill on the 8-5X type of bill, which would kind of be the equivalent to an acute hospital's 1-3X type of bill. We saw errors related to the advanced beneficiary notice of non-coverage and claims with NPI issues. So the provider's National Provider Identifier, something was amiss with that. We also saw timeliness, Medicare secondary payer, and SNF consolidated billing overlaps, like some of our other ones did. So as we take a closer look at these, we're going to review the reason code or codes that appeared in the database on that claims report that I looked at. We'll talk about a brief explanation of what the definition of the code or codes is, and then we'll discuss what we can do to correct and prevent them. If a denial category or a rejection category appeared on more than one bill types list, which it did, we saw that, we're only going to talk about it once because we don't want to be repetitive. No matter what type of bill you're on, the reasons behind the reason code and the ways to correct it are going to be the same. So starting with the first one here, the data showed a series of reason codes pertaining to another insurance. And this is not uncommon. If you've attended any of our quarterly webinars on this same subject in the past, consistently we see Medicare is not the primary payer. So some question of perhaps Medicare being the secondary payer. MSP, very consistent in the top. The reason codes within the FIS system, if you use direct data entry to look at and work on your claims, you'll recognize that the reason codes all begin with a 3-4. And that is because of the way the FIS system works, and I know this is beyond what we're talking about today. The drivers and the reason code spans or ranges. So anything that starts with a 3-4 has something to do with another insurance. The rest of the digits are going to vary depending on the type of insurance that the patient's record is showing as active and possibly primary to Medicare. So that's why I used the X's rather than list them all out. And in a nutshell, that means that the records indicate that the beneficiary has a insert type of insurance plan primary to Medicare. And some of the main ones are listed here. We have working age, disability, workers' compensation, and auto or no fault. The steps that you have to take to investigate and correct, whether it be the claim that's incorrect or the patient's records that need to be updated, are going to be very similar. So if you get a reject concerning another coverage, first thing that I suggest you do is gather the MSP data. And you're going to do that by checking the patient's master record. We have different ways you can do that, or ask the patient questions about coverage. Could be the patient, could be their representative. And you have to do this every time they're admitted as an inpatient, every time they come to your facility as an outpatient, and then if they're going to be receiving recurring services, so identical services that occur more than once in a billing cycle, the manuals state that you have to do this at the start of care and every 90 days thereafter. So I'm thinking things like if the patient is coming to you for outpatient rehabilitation or cardiac rehab, or some of those services where it might be ordered that the patient come twice a week, 3 times a week for 4 to 6 weeks, or whatever the case may be. So those recurring services at the start of care, and then every 90 days thereafter, you're going to be reviewing that information, asking the patient or their representative if anything has changed since they came in last. Maybe their spouse changed jobs or insurance and that needs to be updated. Maybe the beneficiary themselves is still working. Same questions. If the information on the patient's file is incorrect, let's say their retirement date wasn't added. They recently retired and that hasn't been updated yet. You might have to contact a separate contractor. It's called the Benefits Coordination and Recovery Center. They are the only ones that can update the patient's records. If you want more information on how the BCRC, because they have to have an acronym, that seems to be a rule in Medicare, ask them how they can assist you. There is a place on the CMS website about coordination of benefits. It'll tell you about the Benefits Coordination and Recovery Center, what they do, how you can get a hold of them, all of that information. Now, in your research, if you determine that your patient does indeed have another insurance that's responsible for the charges, prepare the bill, send it to them, and then send a secondary claim to Medicare that includes the payment or the denial information. If they made a payment, let us know how much it is. That's how Medicare will determine their secondary payment. If they didn't pay it, let's say it was applied to their deductible or they have maxed out their benefits, and then we need that denial information on the claim so that we can process it. And that's done with some specific coding on the claim. CMS does have some good resources, and we have a slide at the end of this section of the presentation that'll give you some of those and the live links that you can go to read more about the situations. And we also have an MSP playlist on our YouTube channel if you want to listen to some of our past education. So moving on then, we have reason code 39011. This is for claims that were submitted more than 1 year from the date of service, or from the through date if the claim spans more than 1 day. There are some exceptions that have been identified by CMS that may make it acceptable for your claim to be filed after that 1 year. Things like administrative errors, retroactive Medicare entitlement, retroactive disenrollment from a Medicare Advantage or a PACE provider organization. PACE stands for Program of All-Inclusive Care for the Elderly. It is important to remember, though, that an error in making a primary payment determination, so trying to determine who's the primary payer, that doesn't qualify as good cause for waiving timeliness. If your claim's been rejected for timely filing, your remittance advice is going to contain group code CO. So that means that it's provider liable. It's a contractual obligation. So you can't bill the beneficiary for these services, and a timely filing rejection is not appealable because it's not a clinical decision. It's not, there's been no clinical determination on the claim, so it doesn't qualify for appeal. We are in contact on a regular basis with our appeals department, and they still continue to receive a large number of requests regarding other insurance that have been rejected for timely filing. And appeals can't do anything with those requests. It actually holds up processing and correction of your claims because they're technical denials. They don't involve that medical determination to qualify for appeals. Now, what can we do? Well, at the time a patient is admitted, we've already discussed this, it is up to you to determine whether or not Medicare is the primary payer. We ask beneficiaries or their representatives those questions about other coverage. We've checked the eligibility information. Now, if you believe that you meet the criteria for good cause to waive timely filing, there are certain steps that you have to take to have your request considered. And it starts with an original paper claim form. So you have to include a completed UBO4 with a type of bill that ends in a 7 that indicates an adjustment. You have to include any documentation needed to process the claim. A letter explaining why the timely filing deadline was missed, documentation proving good cause. Depending on the circumstance, this could be things like reports or statements from CMS or WPS, official award letters from the Social Security Administration, for example, showing that retroactive entitlement, verification of recouped payments from that other insurance, or disenrollment notifications. So again, reminding you that timely filing rejections are not appealable. Don't send your request for a waiver to the appeals department or in a written inquiry to customer service, because it's actually just going to delay the handling of your requests. Requests to waive timely filing have to be sent to the claims manager at the appropriate state-specific address, which can be found on our website. So now the next one is reason code 33981. And its narrative, remember that's what we call the description, the narrative, says that the claim was submitted with an incorrect value code 44 amount. The calculated, obligated to accept as payment in full, I know that's a mouthful, that amount does not equal the value code 44 amount. The obligated to accept as payment in full amount has to equal the charges submitted on the claim minus the total of the contractual obligation group codes. So that's what that reason code means. That's what it's stating. We don't see this in the top 5 normally, but we did this time. And so that's why we're talking about it. So first we want to review when to use the value code 44. Not every claim where Medicare is the secondary payer will require it. We only want to report the value code 44 on claims when there's a contractual agreement with an insurance company. Value code 44 should not be submitted when the provider did not agree to accept a lesser amount than their charges from the primary payer as payment in full. Another instance when the value code 44 should not be used, when the charges are equal to the amount that the provider agreed to accept. Also, if payment from the primary insurance is more than the amount that you agreed to accept. These are all things that we've seen, and they don't fit the criteria for using that value code 44. Now, the value code 44 should be submitted on MSP claims when the amount that should be submitted on MSP claims when the amount you agreed to accept is less than the charges and higher than the payment received from the primary insurance company. To determine the value code 44 amount, you're going to subtract any contractual obligations from the primary explanation of benefits from the billed amount. This is what Medicare is going to use to determine the secondary payment. So it's very important that it's accurate. When billing the value code 44, you're also going to report the appropriate value code with the amount that you received from the primary insurance company. Those different value codes are specific for the types of insurance. 12 for working aged, 13 for end-stage renal disease, 43 for disability, and so on. So now that you have that information, you can verify the details of your claim. Go back and look at your claim. If it's in return to provider status, that TB9997 location, you can correct it. If it's been rejected, you can do an adjustment to change it. Now, one thing with the value code 44, go back to your billing software and make sure that it's not automatically putting that on every MSP claim. That could be causing part of our issues here. The reason that we don't see it in the top 5 and then all of a sudden we do. We want to make sure that it's not automatically being put on there when it's not appropriate. Next up is reason code C7252. Now, this is a common working file edit, and you'll know that because those reason codes start with a letter, an E, a C, a U, and so on. C happens to stand for crossover. This is just an example. This is an outpatient claim that is overlapping an inpatient Part A skilled nursing facility claim. So it's related to skilled nursing facility, or what we call SNF. I think I've already said that once without defining what that acronym is. SNF, SNF, skilled nursing facility. So it has to do with consolidated billing. To correct and prevent these errors, what we want to do is verify your date or dates of service. If the patient came to your hospital for an outpatient service, they came from a skilled nursing facility and they're going back to a skilled nursing facility, we need to know what their status is at that skilled nursing facility. Not just that they came from a nursing home, but were they in a Medicare certified bed? Were they receiving what Medicare defines as skilled services? Did they have skilled nursing facility days remaining in their benefit period? That's going to help determine whether it's a Part A stay or not. So you're going to have to work closely with your skilled nursing facilities in your area that you're providing treatment for their patients or their residents. Check the consolidated billing exclusion lists. For services that are included in consolidated billing, other what we call outside providers who provide services to residents in a Part A stay at a skilled nursing facility have to seek reimbursement from the skilled nursing facility, and then the skilled nursing facility isn't going to include those services on their Part A claim because it's part of consolidated billing. That's part of how the skilled nursing facility prospective payment system works. Check out the consolidated billing page on the CMS website. There's a lot more details there. I do have a link to it on your resource slide. Next, we saw claims where a service was not separately payable. And we saw the reason code W7047. Its description is shown here. So it says service not separately payable. The charge is included in payment for a primary procedure. So it's something that is bundled or packaged, or it's an incidental service that Medicare doesn't have a separate benefit category for. To understand this reason code, we're going to have to investigate and understand what else may be going on with the claim or other items on the claim. We're going to review any other line item reason codes. So we could have multiple lines on our claim. Some lines could be rejected or denied for one reason, and other lines rejected for another reason, which only leaves incidental services. So different lines may have unique explanations for their status. It could be that the payment is bundled with another code. The status indicator of the HCPCS code might also give us insight, or some might specifically tell us that there's no separate payment for a particular code. Before submitting a claim, you're going to want to review the status indicators for each service that you're billing, each HCPCS code, to ensure that it's paid under the appropriate prospective payment system. If you build an incorrect code, let's say you transpose 2 digits, then you have the opportunity to correct it and resubmit the claim. After you take a look at all the other items on the claim and address any possible issues that you might be having, the reason code might be accurate. It might truly be that there simply isn't any reimbursement for that line charge. Another reason code that appeared on our list of reporting period of February 1st to April 30th is U538S. Again, this is a common working file edit. The U stands for utilization. This edit has to do with a screening cardiovascular blood test being billed more often than every 5 years. The claims that we received were billed with an 80061, which is a lipid panel. So there was no indication on the claim that the beneficiary signed an ABN, Advanced Beneficiary Notice of Non-Coverage. So the provider is liable in these instances. So with this cardiovascular screening blood test, Medicare covers this service for patients without apparent cardiovascular disease, signs, or symptoms. If the patient has a condition that makes more frequent testing necessary, then it's no longer a screening and it should be billed accordingly. So that's one thing that you want to check. If it was done more frequently than every 5 years, figure out if this patient actually has cardiovascular disease. And if so, then the diagnosis code needs to be different. The claim needs to be coded differently to reflect that. You'll need to check the patient's benefits to see when they received their last test to calculate when they are next eligible. As with all preventive services that have frequency standards, an ABN is required when a healthcare provider believes that Medicare may not pay for a service or item due to frequency limitations, medical necessity, or other reasons. The ABN is what gives the patient the opportunity to make an informed decision about whether or not to receive the service and accept financial responsibility if Medicare denies it. Reason codes 52NCD and 54NCD are based on national coverage determinations for lab services. The system has edits in place that compare the HCPCS code and diagnoses on a claim against the national coverage determination. NCD stands for National Coverage Determination. So just looking at these reason codes gives you a clue as to what they pertain to. If it doesn't meet the criteria for coverage based on the diagnoses contained within the NCD, then the line with the lab test denies. It could also mean that for the indication on the claim that are outside of the NCD, they may have been considered if documentation was submitted, but it wasn't. So what you can do to investigate, correct, and prevent this is number one, to review the NCDs for the covered indications for the test that you're providing. If the test is covered by Medicare, but not for the indication the patient has, and you're fairly certain that Medicare will deny it, consider giving the patient an ABN so they can decide if they still want to receive the test and accept that they will have to be financially responsible for it. If you do, be sure to code your claim correctly. When adding the diagnosis codes to your claim, one thing you want to make sure of is to place the diagnosis in the diagnosis codes field and not just another field on the UB04, which is the PRV, Patient Reason for Visit field. We have heard from our appeals department that they are seeing this in a lot of instances. So the claim gets denied, it gets appealed, and when the appeals staff is looking at the claim, they see what would have made the claim coverable, that diagnosis code's only in that patient reason for visit field. And so you run the risk of the automated edits overlooking it, and we don't want that to happen. So make sure that that diagnosis or diagnoses, if it's several, are in the diagnosis codes field. Next up is reason code 31711. And this states that reason codes W7009 or W0235 were assigned to the claim, and the revenue lines contain one of the modifiers that you see listed here. It could also mean that the claim has an occurrence code 32, indicating that an ABN was delivered, but there's no GA modifier. So there's a mismatch, and that's why I use the word inconsistency. So either there was a revenue line that contains a modifier saying that an ABN was given, but no occurrence code 32. And occurrence code 32 is the date that the ABN was administered. So either one is missing or the other, or they're not matching up. So to correct and prevent this, if the claim is incorrectly billed and the claim is in return to provider status, you have the opportunity to go in and change the information on the claim by pressing F9, and updating or storing the claim. So let's say there's a GA but no 32. There's no way that we would know what day the ABN was given. So that's why it's returned to provider, because that's something that only you as the provider or as the biller would know. You are the only one that would have access to that situation. Make sure you are familiar with the ABN guidelines. I don't expect anyone to memorize Medicare regulations. That is almost impossible to do. But become familiar with them, know where to find those guidelines if you need to look back at them. Make sure you're using correct modifiers and occurrence codes for the situation. ABNs are given when an item is a Medicare covered benefit, but due to the patient or the circumstances, it's not medically appropriate in this instance for your patient. If you gave an ABN, add the 32 occurrence code with the date and the appropriate modifier. Now listen carefully to this next part. Submit all ABN related services as covered charges on the claim. If you don't, the system assigns an incorrect denial code and liability. You'll get a message on your remittance advice that just states provider submitted non-covered charges. And that wouldn't be appropriate for you or your secondary insurance probably to process the claim correctly. We do have a link to the CMS Advanced Written Notices booklet where you can read more about its use and its instructions, when you should give it, when you should not give it. Our last category of errors that we have for you today is reason code 17719. This edit occurs on critical access hospital method 2 claims that include the professional charges. Medicare systems reject institutional claims where the billing provider and the rendering physician are reported with the exact same national provider identifier known as the NPI. Now, this isn't a reason code that we typically see in the quarter in the top 5, but we did this time. Now, this usually flags a mismatch or issue with the physician's NPI and their enrollment status in Medicare. The billing provider is the organization or facility, and the rendering physician is the individual treating practitioner. To resolve and prevent this edit, review the name and NPI of the rendering physician that's entered on the claim. The NPI and the first 4 letters of the physician's last name have to match exactly what's on file in PACOS, which is the Provider Enrollment Chain and Ownership System, which is the online system for provider enrollment. While you're in PACOS, verify the enrollment for that rendering physician. Double check that the rendering physician's individual NPI is properly linked to the critical access hospital's NPI and PACOS. Most of the claims that I saw in the data report were RTP'd, so they were returned to the provider. So you could go into DDE and correct those so that they continue processing. If they have rejected, you can either adjust them or rebuild them, depending on whether or not they posted to Common Working File. There's no way that I would know that since I'm not a provider. I don't bill in DDE. You would have to check those claims to see if there was an X in what we call the tape to tape field. And I know that's way more than what we're getting into in this situation here. But if the claim did not post to Common Working File and was rejected, you can submit a corrected bill. So I hope that looking at those different billing situations has given you some insight into the types of errors that we saw in this particular quarter, ones that you might have seen. And if you haven't seen them, some information on what to do if you do see them. Now, the next two slides are the resources that I mentioned. I'm just going to go down the list here. If you download a copy of the slide deck, you have the links. If you're listening to this course as an encore presentation, scroll down to the description of the video and you'll see all the links there. Now, the first one that we have here is a tool on our website, and it's for looking up specific reason codes, details, and getting pointers for correcting rejected claims. So I'd like to take you out there because I have heard that some providers didn't know this existed. So give me a moment here while I bring that up. It'll take just a little bit of time to verify that. A little bit more time to verify that than I expected. But what it can do for you is you can enter in a code, either a FIS reason code or a code from your remittance advice, and it will define it for you. I apologize that that took so much time. So here we are. I link you directly to it. But to find it, you can go up to this top navigation toolbar, click on Tools, All Tools, and then scroll down to the last row. I just happen to know that it's in the last row. Right here, the reason/remark lookup. And I'm going to put in one of the really common ones, and I'll use the one for timely filing, 39011. If you're not sure what type of code it is, you could mark all of these. I happen to know that it's a reason code because we've already talked about it. You have to have at least one marked, and then search. Scroll down a little bit. And so you can see the description or the narrative of that particular reason code. This is verbatim what the FIS system has. So you might see some that are longer, shorter than others. They might have multiple steps. They might be cut off because only a certain number of characters will appear here. But it'll give you an idea. And it specifically says the claim was not submitted timely. And it tells you when that is and what the deadline is. But then also it gives you related content. So we have an article on our website about claims that are filed late with no justification indicated. It also gives you a link to an article that I also have on your resources list called Timely Filing of Claims. And this is the resource that I alluded to when I said there were instructions for how to request a waiver for late filing. I'm going to scroll down. And so here you have instructions on how to file a waiver and where to send it, because it's very important that you send it to the correct place so that it can be handled as quickly and as efficiently as possible. I'm going to go back to our PowerPoint now. So again, there's the link to that timely filing of claims article that we just looked at. Then we have the Medicare Secondary Payer Booklet, which is a CMS booklet. It's an excellent resource for those other insurances that your beneficiaries might have, what the rules are for each of them to be primary or secondary, and so on. The last resource on this slide is a special edition. That's what SE stands for. Special edition Medicare Learning Network publication about Medicare secondary payer situations. Another excellent resource for you. Here are a few more resources that you might find beneficial. Among other things, there's a booklet about using ABNs. We talked about ABNs, when they're appropriate, when they're not. how to administer them to protect yourself financially in those situations. Addendum B is where you're going to find out the status indicators for particular codes. This goes along with what we were talking about, whether or not a service is separately payable. So the final rule, Addendum B, will list those for you. The CMS website's SNF consolidated billing page. This is where you can find out if the service you're providing can be billed to Medicare directly by you, or if you need to bill it back to the skilled nursing facility for payment. And then we have the Medicare coverage database, which is where you're going to find the national coverage determinations, those different lab services that we talked about, and what the coverage criteria and the frequency for some of those are. So now it's time for questions. I know we have just a few minutes left. I did receive a pre-submitted question about the diagnosis code for when a screening colonoscopy turns to therapeutic. Thank you for that question. However, it's not related to our topic today. I don't know what edit it hit, so customer service is going to be the best bet for that question. They'll be able to look at the claim with you and the specific reason code that it's hitting. They'll be able to advise you then what your next steps are. So if that was your question, please contact customer service. So any claim specific questions like that one really do need to go to customer service. I don't have access to the system. I'm not able to see your claim like they can, and that's why. I'm going to check in with Karen, see what questions you have for me. But don't worry, if we run out of time, you'll have another opportunity to send those in. And so Karen, what have you got for me?
Thank you for all that great information, Aline. The first question that we have is from April, and she said that they've had several patients that they come across where workers' comp is primary, but their COB hasn't been updated in at least 10 years. What is your recommendation in this case? The patient states it's not an open common working file case anymore, but it's still listed as primary, and when they advise those patients to call and correct the information, they feel like maybe that's not being done.
Oh, thank you for that question, April. And that is unfortunate, but it's not unusual. Workers' compensation, liability, auto, sometimes those screens or those files never close because people can have effects of that incident or accident years down the road. So what I would suggest, April, is put something in remarks on your claim that it's not related to workers' comp. That should help get your claim processed. Now, if it's more recent, I know you mentioned 10 years, but if it's more recent and it's not due to workers' compensation, or it's questionable, back injuries, some certain diagnoses on the claim will kind of automatically flag that for investigation. But putting information that it's not related to workers' comp or liability, whatever the insurance is, will help. Another thing is if it's still open and it's questionable, bill the claim to that insurance and get a denial. That will also help. So I hope that is helpful for you. Next question.
Our next question is about the timely filing override code. So those statements that they put in remarks where it says justify MSP involvement, Rhonda was asking if those were still valid to do that.
Oh, I know what you're talking about, those verbatim remarks. And as far as I know, they are still valid. Karen, do you have anything to add there?
I would say yes, those are still valid based on my conversations with claims. Um, so it just kind of gives claims when those claims kick out and they have to be manually reviewed, that gives that claim staff a little bit of guidance as to what specifically they're looking for. So I've been told by claim staff that those are still valid remarks.
That was my understanding too. Thank you very much for that information. Unfortunately, we're running short of time here, and I do have some important announcements for you. I hope you'll stay on the line. Anything that wasn't gotten out of the chat as far as questions, I will respond to everyone in attendance with those questions. So thank you for those questions, but we do need to move on, unfortunately. A little bit of information here about overpayment notifications. If you get a request for a refund or an overpayment that's been identified, we know you want to repay Medicare in a timely manner, but we don't want to have delays in having that happen. So if you use an incorrect or an outdated form, that can cause problems. Missing information, or, and this one's important, sending a check without explanation of what it's for can cause a delay. To avoid unnecessary holdups, consider using the Secure Net Access Portal refunds or overpayment claim adjustment features. That's going to be fast and efficient. It's going to process your overpayment and refund that money to Medicare appropriately. There are times when you're not able to use the online portal features. Instead, you may choose to send us a paper request and checks. If so, we recommend including the correct form from our website. I'll have Karen place a link to an article on our website that'll help you determine which action or form to use. This slide is a provider alert. It's announcing a change to the mail delivery for Part A appeals submitted via our portal. Prior to June 1st, correspondence on appeals submitted via the portal, known as SNAP, was sent paper mail. Effective June 1st, all providers with an active SNAP account who submit their appeal requests through the portal will no longer receive those decision letters through the mail. All appeals letters can be viewed and downloaded directly in SNAP, which is our provider portal. Providers will also now receive email notifications regarding a decision on their appeal, and you'll be given immediate access to the appeals correspondence. The next National AB/MAC Ambulance Supplier and Provider Coalition webinar is coming up later this year. Just wanted to let you know that it's coming so you can save the date. It's actually open for registration now, and we're including this slide as just an advertisement from it. It's going to be held virtually Wednesday, September 16th, 12 to 2 Central, which is 1 to 3 Eastern Time. All the MACs are going to present information on current and active medical review, additional documentation requests. We're going to be talking about the comprehensive error rate testing program and how that pertains to ambulance providers. Registrants have the opportunity to submit questions. There's also going to be a live Q&A session. If you want to learn more about the coalition, visit our National AB/MAC Ambulance Provider and Supplier Coalition webpage. I'll have Karen drop a link in the chat. Even if the event doesn't interest or pertain to your job, help us share it so we can get providers the information that they need. All right, take a few minutes, please, to complete a survey about this course. Tell us what you liked, what we could do better, and give us suggestions of topics for future education. Depending on your preference, you have a couple different ways that you can do this. We'll put a link in the chat, or when you exit the webinar, you'll be asked to go to an external site. And that external site is the CMS Qualtrics page for the survey. That's where CMS and us as your contractor can see your feedback in real time. The message is going to look like the picture on the top right side of the slide here, has that triangle and that continue button. If you haven't seen that before, it might take you by surprise. It just wants to take you to the survey. If you're listening to this course as an encore, you're going to see the box with the finger and the stars, and that's going to give you a link to the survey. You can also scroll down the description for the video and find the link. However you choose to do that, please take a couple minutes to give us your survey. In a few minutes, you're going to receive an email that thanks you for attending. And I want to make you aware of it so you don't delete it without reading it, because it contains your certificate of achievement. It has your name, the name of this course, and your contact hours. So if you need to turn that in for credit towards continuing education units, you have it. If you don't see it, check your junk or spam folder. Make sure that you add the WebEx email address to your safe sender list. If you think of a question later, you have 1 week from today to submit a follow-up question. Send it to our same education mailbox. Put today's date and something about outpatient errors in your subject line. That way they will come directly to me. I will provide answers and send them out. On behalf of myself, Karen, Shakura, and all of us in Provider Outreach and Education, I want to thank you for your participation today. We hope to have you join us for future education, and we definitely look forward to your survey feedback. Thank you so much. You may now disconnect.